Dear committee, dear colleagues, my name is Leila Tigharghar, and let me present you my PhD work, which is the management of cervical insufficiency. I'm a resident doctor. I work at the Department of Obstetrics and Gynecology at Semmelweis University. My supervisors are Nandor Ash and Petra Merkeli. My SMS is Isabel Amorim. And my vision is to make cervical insufficiency an easily manageable disease. And my mission is to find the most effective treatment for it by applying up-to-date scientific results. I have 2 ongoing projects at the moment. So my first project is investigating the efficacy of different therapeutic modalities for cervical insufficiency on the prevention of preterm birth. It's a systematic review and network meta-analysis. So a little bit about cervical insufficiency itself. It's the inability of the uterine cervix to retain a pregnancy in the 2nd trimester. It's a painless dilation of the cervix. The incidence is quite low in the general obstetric population, but it's up to 8% in women with a history of mid-trimester pregnancy loss. Risk factors can include conization or inflammation of the cervix, laceration during childbirth, or just a basic structural weakness of the cervical tissue. Despite having such a low incidence rate, it can cause serious things like preterm birth or mid-trimester pregnancy loss. Treatment for it is quite simple. It's either a pessary, a cerclage, or a progesterone. They are all easily accessible, but there is no conclusive data on which is the most effective one. So our aim is to compare these treatments on the prevention of preterm birth. Our clinical question is, which treatment is the most effective at preventing preterm birth in women with cervical insufficiency? Our population is pregnant women with cervical insufficiency, both singleton and twin pregnancies. And we would like to compare cerclage, pessary, and progesterone to each other and measure the outcome of spontaneous preterm birth and fetal death and many other secondary outcomes as well. Our hypothesis is that all 3 interventions have a different efficacy on the prevention of preterm birth. We conducted our systematic search using the population and intervention domains, and in the end, we had over 5,000 hits. This is our flowchart of selection. So we started over 5,000 hits, and in the end, we ended up with 42 eligible full-text RCTs. So here are my results. This is the first outcome, spontaneous preterm birth before 37 weeks in singletons. This is a network plot. The nodes are interventions, and the lines connecting them are direct trial evidence. And this is a league table. It's a table of estimates. On the left side, you can see indirect comparisons, and on the right, you can see direct comparisons. The numbers are odds ratios with confidence intervals, and highlighted in yellow, there is a statistically significant result, meaning that pessary, compared to standard of care, is 49% more effective at preventing preterm birth. Regarding the twins, because of the lack of studies, we couldn't do a network analysis. So we did a pair-based comparison instead. Based on our primary results that pessary seemed to be a quite effective tool, we compared pessary to standard of care or no intervention in the twin group. And as you can see, we have an odds ratio of 0.76, but the confidence interval contains 1, so it's not statistically significant. But it's clearly, it can be clinically relevant. And here's one of our secondary outcomes, spontaneous early preterm birth before 32 weeks in singletons, also a network plot first, and then let's jump to the league table. Same league table previously, the statistically significant result highlighted in yellow, meaning that a standard of care compared to vaginal progesterone is more effective at preventing preterm birth. We, of course, have strengths and limitations to our study. I would consider using only RCTs as the biggest strength of our study, and we also have a good consistency in our network meta-analysis. Limitation, of course, some studies use additional treatments that we could not account for, and a lack of data for the twin studies. Our conclusion is that pessary seems to be the most effective treatment in singleton pregnancies. and it should be considered as a first-line treatment. But of course, further RCTs are needed to compare pessary, progesterone, and cerclage directly. This is my manuscript status. So we submitted to BJOG quite recently. And let's jump onto my second project. It's investigating cervical insufficiency as a risk factor for developing pelvic organ prolapse. It's a systematic review and meta-analysis. So pelvic organ prolapse, or POP, it's the descent of the anterior vaginal wall, the posterior vaginal wall, or the uterus, or some kind of combination of the three. Symptoms can include discomfort, incontinence, tissue bulging out of the vagina, and risk factors can be mainly obesity, constipation, or mainly connective tissue disorders and vaginal delivery. The prevalence is very high, it's up to 40%. And treatment can be either conservative or surgical, but 11% of women undergo surgeries, and a third might need additional surgeries on top of that. So our aim is to assess cervical insufficiency as a risk factor for subsequent development of pelvic organ prolapse. Our clinical question is cervical insufficiency a risk factor for developing POP? Population is Paris women who have given birth before. We would compare a history of cervical insufficiency to no history and measure the outcome, the development of pelvic organ prolapse. And our hypothesis is that a history of cervical insufficiency is associated with an increased risk of developing POP. So here's our preliminary search. The search key consists of the population and outcome domains, and we have over 2,000 hits with this search key. We are in the very early stages of this project because we focused on the first one, which is much more complicated than this one. So the topic is feasible, and we completed the Prospero, and then we will do the rest of the work this summer. So to sum it up, I submitted my first project this June, and I plan to finish the second project this summer and submit it by September, hopefully. And I'd like to thank your attention with my favorite quote: research is seeing what everybody else has seen and thinking what nobody else has thought.
Thank you for your presentation. It's a great work. For your first project, please, I have a question. All these studies use the same pessary tool, or was there like a different ones as well?
No, as far as I know, they were made by the Arabian company, so I just didn't want to say the brand name. So,
please, to a little bit highlight what is network analysis.
So network is when we compare more than two interventions to each other. So we have three interventions: pessary, cerclage, and progesterone, and we would like to compare them to each other.
Can you jump to the slide? Any of
the network plot?
Yeah.
Sure.
Yeah. Because I'm a not so skilled clinician, and okay, and
so the nodes are the interventions, and the size of them demonstrate the population of the patients that had that intervention, and the lines connecting them are the articles, which like measure these interventions, and the thickness of the line is the number of studies.
Okay, great.
Yeah.
And the next, this one. Okay, so you told that the yellow boxes represent those, for example, pessary, compared to standard of care, which are significant results.
Yeah.
So that means any others, progesterone, cerclage, pessary plus progesterone, are non-significantly better.
In this case, yes. So this is the only statistically significant outcome that we could measure.
Oh my God! But you, okay. Please jump to the conclusions. Yeah, pessary is the most effective treatment in singleton pregnancies. Why? The conclusion is pessary is not the next. Pessary is the only effective treatment. in this study, based on
Yes.
only RCTs.
That we could prove statistically. So it can still be clinically relevant to use others. Yeah.
Not significant is no effect.
Yeah.
Okay.
Yeah.
So this is a hard question. When I raised the question initially, and okay, this is true, but I found something more significant than my original question, because this is absolutely significant to do. Except of pessary, I give progesterone, I do cervical. Based on the highest quality RCTs, is a not proved, not effective treatments based on this, and this is a most significant conclusion. So, what your mentors or supervisors think about? Or did you discuss this?
Yeah, they are quite happy with the results, because as far as I know, this is the first meta-analysis that said that pessary is more effective than other treatments. But I think like there's a question like why, because like several studies in the past show that cerclage is more effective than pessary. And there was quite a few new RCTs that came up in the past few years that compared pessary to cerclage and progesterone. So we use those articles.
Okay, please go back to the table. So, for example, about the progesterone, probably there are a lot of randomized trials that prove that progesterone is effective to prevent spontaneous preterm birth in this case. Am I right?
You are. There might not be RCTs, but like cohort studies. So we have like 100 eligible cohort studies, but we only use the RCTs. So this is just result from the RCTs.
Why did you use only RCTs?
Because they like provide the highest level of evidence, and we didn't want to mix cohort studies with RCTs.
Okay. Great, thank you. This is just a discussion. Okay.
I think there's probably a confusion. So, preterm delivery, okay, it's a big box.
Yeah.
And cervical insufficiency is one of the causes.
Yeah.
So if the progesterone is not working, it's probably because it's not working in that way. I don't know what was the criteria for cervical insufficiency
so
in these articles.
It was threefold, like either an ultrasound diagnosis of cervical length lower than 25 millimeters, or a history of cervical insufficiency in preterm birth, or just a physical examination. A short cervix.
That's not easy.
Yeah, I know it's not.
It's not that objective, I would
I
say.
know.
And one more thing is the cerclage. What kind of cerclage?
Like several types.
Was it?
McDonald or Tigharghar, there were like abdominal.
Did they use the laparoscopic way? Because it's much more effective.
There were a few studies that compared laparoscopic to abdominal, but there were like very, very few, so we couldn't include them in the study. And I think most of them were observational studies, not RCTs.
Okay, and this was a therapeutic cerclage, or it was a prevent?
It was a therapeutic, so not a rescue. No. We excluded all the studies that had like ongoing active labor or premature rupture of the membranes or anything like regarding active labor.
So before, it was taken before the shortening of the cervix, or just afterwards?
No, it was given upon like diagnosing the short cervix in the second trimester.
Okay.
Yeah, so all the interventions were done in the second trimester.
Okay, and not as a prevention, but it was a it was a treatment.
Yes.
So congratulations to the project. When you presented it, I thought, wow, that's a mammoth task that you are going for. A lot of randomized controlled trials, and as you said, it's not always one intervention against the other one. It's a whole bunch. So you really went through that whole jungle of trials extremely well, and you presented it very well. You mentioned that the risk reduction in preterm births for 32 weeks or younger was different, right? The vaginal progesterone was kind of the winner. So do you have any explanation why the vaginal progesterone was effective for the very early preterm births compared to the later preterm births? Is it because the endpoint was assessed differently in the trials, or some trials that did not assess 32 weeks or so?
No, I mean, it's still a question that I ask myself, like, what could be the cause of this? I'm not sure exactly. So this is something that I've been wondering myself. I'm really not sure, because I thought that progesterone would prove to be effective, because we use it to this day. And I'm not sure why, but it's a good question.
Yeah, if you would have asked me up front, I would have also kind of picked progesterone vaginally, based on the last trials.
I would like ask about the second project.
Yep.
So you said that there is a higher risk, and those women who had cervical insufficiency with the pelvic prolapse. But what can those results use in the clinic, if you know that there is a higher risk? Okay, and can you prevent this, or can you do something? So what can you do with those dates?
I think the main reason why we should assess it as a risk factor is that we can use conservative therapy like earlier, so we don't run out of time and it becomes a severe disease, and then we have to do surgeries. So we can like prevent unnecessary surgeries by applying conservative surgery earlier.
But before the disease appears, or
maybe just the first sign that.
But there is no symptoms. So if you examine and you cannot see anything,
I know.
can you treat it?
No, but with like very early stages where women are not sure what this is, and then they go to their doctor, and then if we know that this is like a solid risk factor, then we can use conservative measures earlier.
And what can you do in the early stage with those patients?
Pessaries or pelvic floor muscle therapy.
You've mentioned that you have assessed other outcomes as well as preterm delivery. So very likely...
The first project, sorry?
Yeah, for the first project, sorry. So very likely also neonatal outcome, right? Have you any data on that? I know due to the lack of time, you focus on these two, but do you have any inside information about that?
Only one neonatal is the fetal death, but that didn't prove to be significant to either interventions. But other than that, the RCTs did not report much on neonatal outcomes, mostly maternal.
Do you remember how many RCTs have that endpoint incorporated? So neonatal outcome, particularly neonatal death. Is it
around third of the
third or so? Yeah.
Around third, yeah. Okay.
And did these differ from the other ones, like with respect to the efficacy? Did you see any differences when you take the randomized control trials with the neonatal outcome and compare it to the other ones? So, for example, do they have particularly different strategy for the trial or so?
Like how they report the results?
Yeah, if the efficacy is
different. They
different.
were like basically very uniform, so they reported the same way.
Just for the chairs. So thank you for this question. Very common that in such type of in such type of trials, neonatal outcome is not taken into consideration. For example, there was a lot of work on the antibiotic prophylaxis at C-section, whether pre-incision or post-incision antibiotics is better, and found that pre-incision antibiotics much better regarding the outcome of the women. However, intrauterine antibiotic exposure has a long-term associated with a long-term adverse outcome of neonates, resulting in increased number of Crohn's disease and ulcerative colitis. during childhood. So this never was investigated. Probably a good topic for new PhD candidates. So, thank you.
Another question, because you have so many high-quality randomized controlled trials, you can run statistics all over the place, and there are a lot of questions that you can address with this data set that you have. Maybe also the management, the obstetric management changed substantially over the last 10 to 15 years. So have you already looked for the outcome based on when the randomized controlled trial has done? So maybe compare the trials 10 or 15 years ago with the more recent ones 5 years ago, because that might also kind of influence your endpoint. Have you done it so far, or thought of that?
No, not yet, but we have studies from like the 80s to up to like 2023. So yeah, it would be interesting to just look at the past,
for example,
10
kind
years.
of group them in, don't know, 3 different groups up to 2000, 2010, and then 2010 and later. So, and see if that changes the outcomes.
Yeah, but the problem is that like studies from the past 10 years mainly focus on progesterone and the pessary. So like, in the 80s, it was mostly cerclage and bed rest and stuff like that. So.
But that would be interesting to kind of have it as a sensitivity analysis or so, and see whether this overall finding matches in the more recent clinical trials. So if you have the same outcome for pessaries and vaginal progesterone, if you're only restricted to the very latest and most recent trials, that would be very interesting.
Yes.
Yes, so what are direct and indirect comparisons? Maybe go back to, I guess this one also. Yeah.
Okay, or maybe like this one. Yeah. So direct comparison is basically when an article like directly compared those two interventions, like no intervention and pessary. And indirect can be if you compare like pessary to cerclage, which don't have like a direct trial evidence between them, but they have a connecting article between them.
Right. And can you just go back to the table, please? This is not a stats question. This is kind of more of a just wondering. Do you think it's possible that the number of direct and indirect comparisons could like be one of the reasons why like you have like different results for this and the other outcome?
It might be, yeah, and especially the smaller number of studies for different outcomes, yeah.